And thank you for all that who are joining us on this session. And this is going to be, I think, a really important one because Dr. Mee-Lee is going to kind of help us put all of the concepts that he's been talking about together in terms of where do we go, what do we do with these, and how do we use them. So with that, I'm going to turn it over to Dr. Mee-Lee. Thank you.
Thanks very much, Carolyn. Welcome again. This is our sort of last direct webinar, but we do yet still have a challenging case session scheduled for Tuesday, May 3 from 2 to 3 p.m. Eastern Time. But we wanted to, in this webinar, really try to pull together what we've learned and to have a look at what might be some of the implications for drug court teams in relationship to treatment provider teams. But I wanted to just start a little bit about putting this in context of why we're even thinking about these issues of how do we change how we relate to treatment in relationship to criminal justice clients in drug court and other specialty courts. And to see all of what we've been talking about in the context of criminal justice and healthcare reform, because this is a time when budgets are really taking a close look at what do we do about shrinking resources, or at least if the resources that we have, how do we make sure that we use them in a way that's most effective and efficient. So there's an increased demand really for accountability and value. Federal government actually all funds expect resources to be used at maximum expenditures, and especially in the treatment providing service and filling slots. When in healthcare, there's actually a move towards not funding people for doing a service, but funding people outcomes and making sure that any funds that are used are strictly accountable to demonstrate the outcomes from those expenditures. So this is happening in healthcare already, where, for example, if somebody were to come to a hospital and be readmitted within 30 days because they got sick again, in the old days, that would be funded and the person would be readmitted to the hospital. The hospital would get paid for taking care of that person within 30 days, even though you would think, why are they coming back within 30 days? Did really something new come up, or did they not do good continuity in the first place? Now, if a patient comes back within 30 days, the hospital is penalized financially for that person coming back. So what happens now is hospitals are very interested in promoting wellness and continuity of care and making sure that they don't just discharge somebody without a careful plan to keep them as well as possible so that they don't come back within 30 days. I mean, that's what they should have been doing anyway for the well-being of all patients, but especially now when they get financially disadvantaged if a person comes back, they're very interested in continuity of care. So that's just one example in the healthcare field where things are shifting towards a demand for evidence-based practices that demonstrate high quality and cost effectiveness. So the real focus these days is on value. Show me what you're costing me, and are we getting the outcomes and the quality from those expenditures? We're not just going to pay you for putting a person through a program anymore. And that's the pressures that are on healthcare, but increasingly are going to be happening in criminal justice as well. So if we're going to get there from here in terms of the concepts we've been talking about, some of the shifts, what are some of the changes needed? So I want to sort of review again. We've talked about all of these things to some extent throughout the webinar series, but just to give you the bird's eye view, and then we'll go into a bit more detail and review what we've talked about before. But especially as we go through this, I'm interested in you looking at what are the implications of this for your team, whether you're on the drug court or criminal justice team, you're on the treatment provider side. So some of the things we've talked about in the past, and I'll refresh you, are attitudes about addiction as a disease. What do we understand by addiction treatment? How do we understand relapse or substance use while a person is in treatment? And then also looking at how do we look at mandates for abstinence when you're talking about a disease that is defined by being out of control. If people are not just drinking and drugging because of willful misconduct, how do you actually mandate abstinence, which is characterized by flare-ups and use? We have talked about based phases versus functional improvement phases, and levels of care and flexible stay, not a particular program and a particular length of stay. And then we've also talked about mandates for AA attendance and whether that's appropriate for all clients and participants. This impacts how we think about sanctions and incentives in our policies when somebody gets a positive drug screen. And we'll review again the importance of understanding the difference between. Finally, how do we bring this all together, working and collaborating on this? No one stakeholder has all the answer to this. So a reminder that, let's see, is that better? It sounds like my sound may not be consistent. Just let me know if my sound's not coming through well. We want to make sure that when we notice the difference between criminal justice systems and treatment, and really recognizing the difference between compliance and adherence. So to comply is to act in accordance with another's wishes and with rules and regulations. And this is appropriate to a criminal justice mission, and we'll go over that in a second. But when we're talking about getting people into treatment and helping them to make real changes, we need to think more about treatment adherence, because change is difficult to do without good faith effort where people cling to and clip and stick fast with the treatment plan and treatment. So that we now want to make sure when we're talking about a criminal justice mission, compliance is appropriate way to think about what a person has to do in relationship to court mandates. But when we're talking about treatment, we're really talking about the importance of adhering to treatment and sticking to the treatment plan. So just to remind us that from a criminal justice point of view, it is correct to focus on consequences, compliance, and control. That you can't have laws of the land if people aren't expected to comply with them because they're trying to control public safety. And if you don't comply with the laws of the land, there are consequences. And this is an appropriate mission when we're talking about public safety and crime and safety for the public. And we want to make sure that there's a distinction, however, between what the mission of criminal justice is and what the difference is when a person is mandated to treatment. Because when a person is mandated to treatment, the thesis is we think this person will respond to treatment because they have the illness of addiction or mental illness or both, and we think give them a chance for treatment and they will increase public safety by getting into recovery and therefore decrease offending and crime and legal recidivism. So the mission for treatment is different from consequences, compliance, control. Those are not the principles in treatment because we don't want somebody just to comply and to sit through a treatment program. So we've been talking about the ASAM criteria, and you can see much more about ASAM at asam.org. And we've been talking about the ASAM criteria book, the principles within that, and you can see more about that at asamcriteria.org. So I'm going to review, we started off the webinar series with what is state-of-the-art addiction treatment, and how do the ASAM criteria help to define that for people. And here are some of the ways that I thought you might have a takeaway in terms of what are the implications for court teams and what's the implication for treatment provider teams. And of course, I welcome any time throughout the webinar and even after that, if you have questions or comments or disagreements, this is really about opening up a conversation about how do we get there from here and what would be the implications for each team in terms of really implementing a different way that we've been operating in terms of the interface between treatment and specialty courts. So for the court team, I would remind us to think of addiction as a brain disease, not just a behavioral problem. And by brain disease, I mean that it is to deal with the brain reward system, but of course addiction isn't just a brain disease. It does affect behavior, and it does affect relationships and psychiatric and mental health issues and physical health issues. So it's really multidimensional in the way that it expresses itself and in the way that we have to address it. So what's important for court teams to remember is that this is not just a behavior problem where people are drinking and drugging, and therefore we need to do behavior therapy and cognitive behavior therapy and behavioral methods to somehow reward or punish bad behavior. That is a very behavioristic model as opposed to an addiction disease model. And the addiction disease model, of course, still focuses on the accountability for behavior, but puts it in the context that it's not just a reward and punishment behavior modification process, because behavior is just one part of the overall disease of addiction. Now, related to that, for treatment provider teams, what's important for them to do is to make sure that they are providing active treatment to somebody and not just getting the person to comply with court mandates to do treatment. So a treatment provider, when a participant from drug court or specialty comes to treatment, they need to provide active addiction treatment, expect client adherence and accountability, and not allow a person just to sit in a program and through basically reporting to the court that the person's in treatment, because we'll talk about this later, and you've heard me talk before. It's the difference between doing treatment and doing time. For the court team, a second thing to remember is to understand the complexity of addiction. We don't want to make it overly complex to sort of just make it complex for the sake of making it complex, but the fact is that addiction is much more complex than just behaviors. And it isn't just about you drinking and drugging. Stop it, and I mandate you to be abstinent. If the person has the disease of addiction, then court teams don't have to be expert in understanding ASAM criteria and multidimensional assessment and the whole range of evidence-based practices and treatment, but they do need to understand that when you refer somebody to treatment, it is much more than placing them in a program and expecting them just to comply. It's really about expecting from the treatment provider a thorough assessment and understand that when a person goes to treatment, if the treatment provider isn't providing the kinds of multidimensional assessment and holistic outcomes-driven treatment, then the court is not getting their money's worth, as it were. For treatment providers, it means making sure that they do that kind of individualized treatment and use a continuum of care, not just residential care, and to make sure that they are moving that person through that continuum of care based on functional change in a way that makes sure that their length of stay in any one level of care is not based on a pre-designed phase, but in terms of, is this person actually changing? So just to note that somebody's attending and complying and can show a check off that they attended an AA meeting doesn't really mean the treatment provider is doing the kind of job it should do for treatment. Court teams need to expect substantive reports from treatment providers on the client progress. Court teams should be told about, is this person making a good faith effort, and are they actually changing to bring about public safety, not just a brief report that says the person is attending treatment, complying with drug screens, and going to AA meetings as mandated by the court. A report should provide, from the treatment provider's point of view, enough information to the court to demonstrate that there is a client in active addiction treatment, and to advocate with the court for individualized treatment, not just having the court say, I mandate abstinence, so many AA meetings, and such a length of stay in a residential treatment. But treatment providers then have to give the court enough information to make the court comfortable that real treatment is going on. The fourth point in this is that court teams will need to collaborate with treatment to make sure that the treatment plan is matching the progress of the participant. So the recommendation I'm making is that the judges mandate treatment adherence, but not treatment plans. In other words, that's outside the scope of the judge to know enough about multidimensional assessment and treatment to mandate a particular treatment plan. Like you have to go to so many AA meetings, and you have to have a sponsor, and you have to stay this length of stay in this treatment level. The judge, in my recommendation, would be to mandate treatment adherence, which then puts the responsibility on the treatment provider to build trust with court teams, to allow individualized outcome-driven services, so that treatment providers need to be proactive to inform court teams anytime there is a danger of public safety, because the court team is naturally concerned about that. And we sometimes think that we can protect public safety by just mandating somebody to long lengths of stay in a residential treatment program. That doesn't guarantee real functional safe change. That can turn into just somebody doing time in a residential program, and then once they get out, things blow up because they haven't actually changed. So treatment providers have to build a trust with court teams to give them enough information to say, we're on top of it, we'll let you know if public safety is becoming clear because the person's not actively involved in committed good faith treatment. But if the participant is involved in treatment and they're not perfect, please don't mandate sanctions and don't mandate the treatment plan when that's not based on a careful multidimensional assessment. So to summarize about addiction as a brain disease, and you can see more at the links I gave you, addiction's a primary chronic disease of brain reward, motivation, memory, and related circuitry. This is ASAM's definition, and that dysfunction leads to then multidimensional biological, psychological, social, and spiritual manifestations. And that's why we have to do holistic, multidimensional care that the ASAM criteria talks about. When people have addiction, they pathologically pursue reward or relief for their brain reward system by using substances and by other behaviors like gambling and internet gaming disorder, compulsive addictive behaviors. So addiction is about brains, not just about behaviors. It's not just bad behavior which needs to be treated with behavioral techniques and reward and punishment. It's much more holistic and multidimensional than that. So that means individualized treatment, where if somebody is doing well, we then keep working through phases of the drug court and treatment cycle. But if they're not getting better, then the treatment plan has to change, and that means continual assessment of progress and checking on a good outcome or a poor outcome. And a poor outcome would be not showing up at treatment, would be using, would be having mood swings and angry outbursts. All of these things are treatment issues, not just rule-breaking issues in a behavioral modification way. The 6 dimensions, we won't go into detail, we've gone over that, but just a reminder that these are the areas that a court team should be expecting a treatment team to be thoroughly assessing and treating any aspect in those dimensions that's going to threaten public safety and that is needed to change to help this person actually make lasting positive changes towards recovery. And when we think about criminogenic factors, we've often in criminal justice settings focused just on the criminogenic factors on the left side there, which are related to high risk, high need in terms of reoffending and criminal reoffending recidivism, but those are not the whole story in terms of treatment for addiction. These areas are important, but when a person goes into treatment, we have to address criminogenic factors, but in the context of the other dimensions. So you can see that each of these criminogenic factors are relatable and have implications to the dimensions in the ASAM criteria. But if treatment is just focused on criminogenic factors, we're going to miss out on an important part of treatment to create lasting change. Then we had a webinar series about doing time or doing treatment, and how do we move beyond program phases to really focus on lasting change. And the reminder that I would give to court teams is, how could we begin, and this is sort of opening up the conversation because this sort of thing can't change overnight, but how could we begin to start modifying phases in drug court and other specialty courts away from time and compliance, and I call that doing time, to demonstrated functional change and adherence to treatment. And that's about doing treatment and doing change. When we send somebody to the treatment, the court should be expecting to see, is this person doing treatment, doing change, not just sitting in your program doing time. And that means looking at how we word phases through the court to focus much more on demonstrated functional change than on phases based on time. Now, we have that to a certain extent already, where you don't move to the next phase unless you've had sufficient negative drug screens. But we all know from drug testing that many participants can produce negative drug screens by all sorts of tricks. So again, just producing a negative drug screen doesn't equate to real functional change. Treatment providers, if we're going to move beyond just phases based on time to function, have to then provide stage-matched strategies and individualized treatment that expects good faith effort from the participant in treatment, not just sitting in a program. So that means that a participant who goes into treatment who's ambivalent about whether they even have an addiction problem, that's fine. That's what the treatment's going to focus on, helping them to work through that ambivalence. Or if a participant even thinks they don't even have a problem with addiction, they're not even ambivalent, they don't think they have a problem with addiction, they're basically just there to get through drug court and do less time, that's fine too. The treatment provider can work with that person in a motivational way, but those treatment plans are going to be quite different from the participant who now recognizes that their legal problems have caught up with them, and this has really propelled them to realize, I better change my life and get into recovery. And you do have those participants too who are ready to do whatever it takes to get into recovery. Their treatment plan is going to be quite different, and the pacing through the phases might be quite different from somebody who's ambivalent or doesn't even think they have a problem. They both need treatment, but the pace with which they move through phases shouldn't be based on a one-size-fits-all time process, but on a function-based demonstrated change. So the second point for the court team is that it's important to collaborate with treatment providers, expecting them to give robust reports that track progress through stages of change, and to reassure the court that this person is actually making functional progress. So for the provider treatment team, you, as we mentioned, have to give substantive reports that track the participants' progress in real pro-social functional change. And as I said, not just reports that address compliance with court orders. We've talked about sanctions, and that we want the court team to consider sanctioning for lack of good faith effort in treatment. Don't sanction for out-of-control addiction signs and symptoms. And out-of-control addiction signs and symptoms are when somebody's using, or somebody's relapsing, or somebody is demonstrating a negative attitude because their disease is sort of getting active again. We want to make sure that those are seen as sort of normal in terms of addiction treatment, needing assessment and a change in the treatment plan, not sanctioning for the behaviors that are part of the disease. And then, of course, to look how can we use incentives more than sanctions to attract people into a recovery process. But you need both. You need incentives and graduated sanctions. Sanctions for when, as in number 3 there, from the treatment provider team, to recommend to the judge when a sanction is needed, because basically the participant is not participating. It's just he or she's just sitting in treatment. They're not adhering to their treatment plan, and as such they are out of compliance with the court order for treatment. Now, clients will say, well, what do you want me to say? I'm here, and I'm in compliance with the court order. I'm in treatment. Well, no, just sitting in treatment and drifting through and not really participating and not even knowing your own treatment plan is not doing treatment. So if a treatment provider sees somebody's like that and are sort of pulling teeth with them, or a good clue is whenever a treatment provider feels like they're doing more work than the client, then that is an indication that the client is not an active good faith participant in treatment, and they should be informed that you're going to recommend to the judge a graduated sanction for not adhering to treatment. Court teams collaborate with treatment to use incentives that advance participant recovery goals and inspire lasting change. By that I mean, can the incentives be more robust than a gift certificate or some kind of material good or some kind of restaurant certificate? What would be an incentive? And this is where the treatment team talks with the court team about, from a careful assessment of this person, here's an incentive that will help promote recovery and engage this person in a self-change process. They haven't seen their kids. They have been restricted from seeing them because of some, restraining order, or because kids have been taken away from them. And it is very important for them to reunite with their families. So an incentive would be if they start demonstrating real functional change and negative drug screens and improved thinking and attitudes and behavior, then an incentive would be to arrange for a supervised visit with their children initially, and move to even more freedom for visits with ongoing demonstrated change. Or if somebody is wanting to get housing or a job, then an incentive would be to help them with their resume, or to help them with interviewing skills, or to help them with developing a budget. These kinds of incentives should be part of treatment anyway, but can be especially focused on for an individual who this would be an inspiration to start making real recovery and real changes. So a reminder about stages of change work, Prochaska and DiClemente, really looking at not everybody is at action for recovery from day one. And when we give court mandates as if everybody is at action for recovery, you will be abstinent and you will stay abstinent, that doesn't fit with where the participant may actually be. And what is important is that the treatment provider assesses what stage of change the person is. And remember, a stage of change isn't just a fixed stage. You could have a participant who is at action for completing drug court and doing less time, but at pre-contemplation for seeing that they have a severe drug problem. You could have a participant who's in contemplation, ambivalent, that maybe I have a drug problem, maybe I don't, but is willing to start looking at things and move towards preparation. Or you may have somebody who's at pre-contemplation for marijuana, thinking I don't have a problem with marijuana, whereas they're at preparation for methamphetamine. Yes, I do have a problem with methamphetamine. That's ruined my life, but it's okay to keep smoking marijuana. In other words, even within addiction treatment, there are different stages for different things. Let's see. We have then staged match interventions that relate to the particular stage. So when you mandate a relapse prevention plan for somebody who's not even thinking they have an addiction problem, that is not a stage-matched intervention. First, we have to help that person realize they have a problem. That's part of what treatment is and what we've called before a discovery dropout prevention plan. Whereas if somebody is at action for recovery, then by all means a recovery relapse prevention plan is appropriate. But this is, again, where we're encouraging court teams not to mandate abstinence and relapse prevention, but to be guided by the treatment provider about what would be the treatment plan that would be expected for this person at their particular stage of change. So for court teams, when we're trying to engage participants in a self-change process, we're trying to recognize that lasting positive change cannot be mandated. You can't mandate non-psychosis, non-depression, non-panic attacks, non-mania, non-suicidality, and non-substance use. You can mandate treatment to then get into recovery, but you can't mandate perfection. Well, of course, we would love it if we could mandate all people with addiction problems. You are mandated to be abstinent and to remain perfect and never reoffend again. But the problem with addiction is that if it's a disease for this person and not willful misconduct, because there are people who use drugs and offend because of willful misconduct, not because of the problems of an illness, of course, they should take the consequences of their actions. But if we decide that somebody has addiction and that they could benefit from treatment for the public safety, then we mandate assessment and treatment adherence, not a particular level of care or a particular length of stay. Now, for the treatment provider team, then, that means engaging that person in a recovery process. So understanding that people go through stages of change, a treatment provider has to start with identifying what the client is at action for. It may be that the client is coming in, I just want to get get people off my back, or I want to get my kids back. And that's all right for them to say that. That's where we're going to start. Or I just want to complete drug court. Or I just want to make sure that I do less time. Or I'm not interested in this recovery thing. Well, that's fine. That's normal for people with addiction. Very few people with addiction are ready to change their whole life from day one. But the treatment provider's responsibility then is to engage that person starting where they're at and then help them to see how they are shooting themselves in the foot in terms of getting their children back or getting people off the back or doing less time because of what their addiction has done to their biopsychosocial spiritual life. Court teams need to recognize, number two there, that there is never a smooth, positive progress with no bumps in it in terms of addiction recovery. Very few people decide to stop using and then never use again and go ever onward and upward in recovery and in pro-social and self-sustained, self-sufficient life. That recovery is as normal for there to be relapses and flare-ups and setbacks, and the fact that that happens should not be a surprise to court teams and should not be sanctioned if a person's in good faith doing treatment. Now, of course, if somebody has a flare-up or a relapse and they say, I don't care, I'm not going to change my treatment plan, then by all means the court should sanction for lack of doing treatment. But don't sanction for flare-ups and relapse, because a smooth, positive progress is most unlikely for clients. Treatment providers then in this context need to identify with clients, if they have a setback, what went wrong, and to work with that participant to change the treatment plan in a positive direction. And if the person is willing to change the treatment plan in a positive direction, you keep proceeding and making sure that we inform the court team that this person is not perfect and they still have lots of issues and they even got a positive drug screen, but treatment is on track. So let's keep treatment going. Now, the court team then has to see that when bad outcomes happen, they should be expecting the treatment provider to reassess what happens and to change the treatment plan. And if the participant is willing to change the plan in a positive direction, treatment continues. But the treatment team needs to report to the court team if there's a problem and how the treatment plan has changed, and if treatment is going to continue, or whether to recommend a sanction if the person is not doing treatment. So that's the other piece of this, that treatment providers have to advocate for continuing treatment, because even though there was a poor outcome, things are moving in the right direction and the person is in good faith doing their work, or to recommend to the court a graduated sanction if the client is not actively participating in treatment. So related to this, court teams need to expect accountable, good faith effort in treatment and not passive attendance and compliance. But that takes some communication because from just looking at a positive drug screen or bad behavior, if not put in the context of treatment, the impulse might be to take a criminal justice focus on that and create a consequence and a sanction. Now, we talked about relapses and flare-ups, and so this is related to this as well, but just a reminder that when you think about a relapse, it really is only a relapse if a person has been in recovery. In other words, you can't have a relapse unless you first thought you had a problem, wanted to stop, did stop, and then got into recovery. If then you use, that's a relapse. But for many of the participants in drug court and in treatment, especially early on in treatment, their use is just continued use, or mental health court, their problems are just continued problems. It's not really a relapse. So the reason for making the distinction for this in our terminology is that if somebody uses, if both the treatment provider and the court team sees this as a relapse, we may miss the importance of working out what actually happened in terms of that substance use, because that substance use may not be where somebody had a relapse, but where they're still struggling with whether they even have a problem or whether they know how to cope with negative feelings without using. So the court team needs to expect from the treatment providers an analysis of what happened when a person actually had a relapse or a poor outcome or use. So the treatment provider team works with the participant to assess how to improve the treatment plan. Another point to remember is that if people have a relapse or if it's a flare-up or poor outcome, it's not just a simple thing of, okay, the participant used willful misconduct. It's, again, multidimensional in terms of why people have poor outcomes. It may be a variety of things where you have to go through actually the 6 dimensions and see, is there some cognitive problem? Is there some behavioral problem? Was there a chronic pain problem that hasn't been treated and well stabilized? Is there a personality disorder? Is there a co-occurring mental disorder? Are there some changes that happened in the recovery environment that caused this particular flare-up? And so the treatment provider team has to be prepared to inform the court, these are the reasons for this person's flare-up. Treatment is happening, so don't be concerned about public safety, just the fact that they used. And here's the rationale for continued treatment, because we now have a pretty good idea about why this outcome isn't going well, and the person is willing to now address their chronic pain, or is willing to address the fact that they are hanging out with the wrong people, or they're willing to address their co-occurring mental disorder. And so it is a matter of understanding that relapses and flare-ups are complex issues that need a specific change in the treatment plan. So court teams should expect the provider to go through the ASAM criteria multidimensional assessment and improve the treatment plan, but the court team can't be expected to understand or know all of that unless they have a particular interest in learning about that. That really is the responsibility of the treatment provider to be proactive in informing the court if treatment is going well, and then to recommend to the court how to modify the frequency of court visits depending on the client progress. So how frequently a person goes to the court shouldn't be based just on a phase or a procedure that one size fits all, but on whether they're actually progressing and changing. Just a reminder that if any of this isn't making sense to you in real time, please Monica knows to interrupt me and to let me respond to that as we go. You don't have to wait to the end, because sometimes you forget what the issue was. So if anything of this doesn't make sense to you or you disagree with it, we want to open up the conversation. So feel free to type in a question or a comment or a disagreement, and I'll be happy to be interrupted. When we're talking about relapse, the third point there is to remember that medication may be a necessary part of an effective treatment plan. And it's up to the treatment provider then to assess whether medication should be in the treatment plan to improve outcomes, and to recommend to the court if meds are indicated. So it isn't just all behavioral treatment or therapy or groups. Biomedical, physical medication may be helpful. And so in this slide, I just put in a reminder that when we're talking about MAT, which is really used to say medication-assisted treatment, I prefer to say medication in addiction treatment, because MAT is not a philosophy. It should just be medication in addiction treatment. In other words, some people, both on the treatment provider side and on the court team side, think of MAT as a philosophy. I don't believe in MAT, or I don't believe in doing that. It's as if it's some model. Well, it's not a model. It's just like a medication in any other disease. When you use medication for hypertension or diabetes or depression or schizophrenia, it's not a philosophy. It's just one of the tools in the toolkit. It's, does this person need medication to improve the outcome, to improve public safety? Some people need medication, some people don't. And there are medications for alcohol use disorder, for craving, and for helping people been around forever, disulfiram or AND abuse, to be a particular support in making a person think twice before they drink. So medications, of course, in alcohol use disorder for withdrawal management. There's medications for opioid use disorder. In the current opioid crisis, we've been hearing a lot about different medications to reverse overdose, but also, of course, for methadone and buprenorphine, for maintenance medication, and for naltrexone, Vivitrol. And there are medications for nicotine and tobacco use. One of the forgotten aspects of addiction is that nicotine addiction is very serious as well. So again, the point is, don't think of MAT as a philosophy, but think of it as a necessary tool for some participants to have a good outcome. Now, I wanted to talk a little bit about terminology. We talked up front about the difference between compliance and adherence. I want to just alert you to some other terminology, not to make you self-conscious about using this, but to recognize that language matters and it can influence attitudes. And one of the most difficult things with addiction is that the general public and even people more familiar with addiction in drug courts and treatment providers, there's still a lot of stigma that stops people with addiction getting the help they need. I don't know if you've ever tracked the National Survey on Drug Use and Health. This comes from the Substance Abuse and Mental Health Services Administration. And every September, they put out a report on the National Survey on Drug Use and Health where they actually survey households about the alcohol and other drug usage. And for people 12 years and up, there's about 22 million Americans who need addiction treatment. But only a tiny sliver of those people get into addiction treatment. Maybe about 10 million get into actual treatment, partly because of the stigma around addiction as a disease. And of course, there's other things as well, insurance, and the very nature of addiction where people don't think they have a problem. So some of the terminology I would just invite you to reconsider is when we talk about dirty and clean drug screens. Because if you say somebody is dirty in their drug screen, there's an implication that the person is dirty too. Now, I know you may not mean that when you say your drug screen's dirty, but it's a terminology that contributes to stigma. Clean is good, dirty is bad. When really it's just a positive or negative drug screen. We don't say your cholesterol is dirty or your blood sugar is dirty or your chest day was dirty. It's just, was it positive for cancer? Was it positive for TB? Was your blood sugar level too high? And was your cholesterol too high? So it's really trying to extricate ourselves from language which is often connoted really that people with addiction are out of control and dirty, as it were. Now, one that's getting a lot more attention in research, and it's very common for us to refer to addiction as substance abuse and to refer to somebody with addiction as a substance abuser. Even now, federal government, it's the National Institute of Drug Abuse and the National Institute of Alcohol Abuse, and it's the SAMHSA, the Substance Abuse and Mental Health Administration, CSAT, and all of these federal agencies still often use the term substance abuse. And I would encourage you to start moving away from substance abuse and substance abuser, because substance abuser gets linked with child abuser, sex abuser, elder abuser. the term abuser is a stigmatizing term right from the start. And in terms of substance abuse, people are abused, not substances. In fact, my colleague Norm Hoffman makes the joke that substance abuse is kicking a whiskey bottle on the sidewalk or putting water into good whiskey. That would be substance abuse. But when we're really talking about the addictive use of alcohol or pain pills, that's what we mean by substance abuse, where somebody is using a drug in an addictive way, which is part of their disease of addiction. And so we want to say not a person who's a substance abuser, but a person with substance use disorder. Now, you may say, well, this just sounds like political correctness and, it's much easier to say substance abuse and substance abuser. Well, it is easier and quicker to say, but it continues stigmatization. And John Kelly, who is at Harvard, has done work on this, and others have too, where they gave a little clinical vignette to treatment providers. This is people who are working with people in behavioral health. And in one vignette, they described the person as a substance abuser and having substance abuse. And then in the other vignette, all the details were the same, but instead of calling the person a substance abuser and that they were involved in substance abuse, they talked about a person with a substance use disorder. And there was a difference in how both vignettes were viewed by treatment providers. Where the person was called a substance abuser, there was much more of an attitude of this person needs to be contained, or this person needs to be kind of punished for their behavior, versus when you said a person with substance use, that invoked much more attitudes of this person needs treatment and more attitudes of compassion than when the person was described as a substance abuser. And I gave you references, and at the end of the slide set, there's a bibliography where Richard Seitz, who is the editor of the Journal of the American Journal of Addiction Medicine, the ASAM scientific peer-reviewed journal, where he wrote a editorial that under his editorship, that he's just taken over, we're going to be very careful about using language and using person-first sort of language. William White has written a lot about this too, and this is not just in the addiction field. This is being looked at in terms of people being called schizophrenic, being called borderline, being called an obsessive compulsive, being called a sociopath. These are all terms that invoke less compassion and increased stigma than saying somebody with schizophrenia, or a person with bipolar disorder, or a person who has an antisocial personality disorder. Another terminology issue is addiction. Now, the disease is addiction, and some people have addiction with substance-related addiction, alcohol use disorder, opioid use disorder, and some people have addiction with addictive behaviors like gambling disorder. So you may feel this is splitting hairs, but those of us who work in the field of addiction really call it the disease of addiction, not the addictions. So it isn't like you have different addictions. It's the disease of addiction that gets manifested with alcohol use or opioid use or gambling. But the disease you're treating, like diabetes, is diabetes. It isn't the diabetes. It isn't the hypertensions. It isn't the depressions. It isn't the schizophrenias. It's the disease of addiction. So just trying to raise awareness of how language can sometimes influence attitudes, and especially certain terms, dirty and clean and substance abuser, contribute to the continued stigmatization of addiction. So how do we get there from here? Well, we have to recognize that we all all want the same thing. We have the same common purpose and mission. We want increased public safety. We want safety for children and families. We want decreased legal recidivism. We want decreased crime. We want recovery. We want people to be able to embrace well-being and to make sure that they're not just going from one crisis to the next and from one incarceration to the next, but are actually making positive, lasting change. That's the power and the success of drug court and other specialty courts, to shift away from incarcerating people, which costs a lot but doesn't really rehabilitate people anyway, and too easily becomes a school for becoming a better criminal, and then shifting for people for whom it is appropriate, where their offending has been related to an illness, then giving them that treatment. So we all have the same mission, but the problem is we come from different perspectives, and especially when it comes to treatment, we have to have a common language to assess stages of change and multidimensional assessment. We have to have a common consensus on how do we deal with the fact that not everybody is at the same readiness for recovery, so we can't mandate abstinence as if everybody's ready to do that, because that encourages a compliance mentality, not an adherence change mentality. But it means that we have to have consensus on how we get to combine the power of the court and the law and the consequences of offending behavior with the resources of treatment, with multidimensional assessment, where we can use the leverage of the court to effect real change, responsibility, and accountability. But that takes careful collaboration and communication between addiction treatment teams and mental health treatment teams and court teams, and recognize that we will have conflict and that there's not a problem with conflict. In fact, if there's not conflict, somebody on the team is not speaking up for what they believe. There's no way you could have universal agreement on everything when people are coming from a different set of eyes through the criminal justice perspective versus the treatment perspective versus the child protective services perspective versus probation and parole versus defense attorneys and prosecuting attorneys. Everybody has an important stake at the table, and how do we actually begin working together? So this was meant to open up a conversation, this whole webinar series, about these issues: attitudes about addiction, court mandates for abstinence, time-based phases, levels of care, AA attendance, sanctions and incentives, and then how do we actually work together to get the outcomes we all want. So I would love to open it up to you to think about what questions or comments you have. While you're doing that, there is just a reminder that the resources, if you want to look at some resources for implementing assessment of the 6 ASAM dimensions, there are some workbooks, or what we call at the Change Company's interactive journaling and evidence-based practice, and you can see some electronic pages of that at changecompanies.net, and you translate that into a treatment plan, which can be tracked in a collaborative way with the client. There are 200 different journal titles, but one specifically for drug court. You can take a look at that, where this helps to implement motivational interviewing, cognitive behavior therapy, stages of change work, and so forth. If you want to get more training on the ASAM multidimensional assessment, there's an e-training series, 5 hours on multidimensional assessment, 5 hours on assessment to service planning and level of care, stop and start when you want, and then an introduction for 2 hours to the ASAM criteria. Bibliography for you, you can take a look at that, and then other websites to help you, and a reminder that we're looking for challenging cases or vignettes for May 3 for 2 to 3 Eastern, which will be our final session together. Monica, do we have any questions, comments that have come through?
We do. One individual says, how do we begin to incorporate the idea of functional milestones over compliance to mandates and time? Are there recommendations for small steps that could be made?
Yes, well, I think if you look back at the webinar that we did on moving beyond phases, we did put in the PowerPoints there some examples of trying to move away from time-based phases. So if I can give you an example that might, you know, sometimes we have a court mandate, for example, that a person has to attend so many AA meetings. Well, if the treatment provider assesses that AA meetings aren't the best way for this person to actually get into recovery and make changes, and that they are better suited to function better in a community of faith, or if they have a cultural tribe or support system that is better for that person, then what you might say in the phases is that a person develops a meaningful support group that to which the person is committed and is going to follow through with, and that then is putting the focus on the function of the person developing a recovery support group that they will keep attending and reach out to, rather than go to an AA meeting, get it checked off that they attended, then go outside smoking cigarettes or not even participating in the meeting, just to show that they've complied with the court order to go to an AA meeting and not actually change. Now, I'm not saying everybody does that. There are people who go to an AA meeting and they have a spiritual awakening and change, and but then that's what the treatment provider would be saying. This person is actually changing in their attendance and getting a sponsor. So when phases talk about, is this person demonstrating functional change in terms of the relationships they're hanging out with, such that it increases public safety, that would be a shift to functional change. Is this person demonstrating a bonding with a recovery group that is meaningful to that individual? That would be demonstrating functional change, as opposed to compliance with attendance at meetings, or compliance with you are to get rid of those friends and not hang out with them. So those are mandates that are not functionally based, but a one-size-fits-all. So a treatment provider should be able to demonstrate in certain phases that a person is actually making changes, that they are safe to go to recovery groups on their own, unaccompanied. And so these could be written into phases where you could begin to look at, in any of the 6 dimensions, where is a person actually changing. For example, if somebody has a chronic pain problem, that it might be described that if a participant has physical health problems that jeopardize recovery, that they are addressing those in an individualized way that is showing that they are not fixed on pain pills as the only way to deal with their pain problem, that they are participating in physical therapy and mindfulness and relaxation methods and so forth. So it's really working with the treatment provider to start actually defining for that particular client what would be the functional changes that we would expect to demonstrate this person is entering recovery, not just jumping through hoops.
Great.
Anything
Thank you,
else,
Dr.
Monica?
Mee-Lee.
Yeah.
Yes, we do have another question. In regards to what you spoke about today about the court team versus the treatment team, where would the case manager fall on a drug court team? And then in addition to that, where would the position of the drug court coordinator fall?
Yeah, so let me make sure I understand. The drug court coordinator, I understand, is coordinating all of this. So let me talk about that first. the coordinator really is coordinating, which means bringing those both sides together to make sure. So, for example, say the coordinator gets a report from a treatment provider and they can see that the report is just person attending groups, giving negative drug screens, and attending AA. Hopefully now, with this discussion, the coordinator would say that's not a substantive enough report. That's not going to help the judge know whether this person is in good faith in treatment and actually making changes, or whether they're actually just sitting there and actually the public safety is more threatened. A court coordinator would be the person who the treatment provider would say, look, this person got a positive drug screen, but I want to make sure the judge knows what's happening. And so I know many court teams have treatment providers and they meet before court and you discuss cases, but perhaps there's information that needs to get to the judge and the court team before that meeting. Or it may be that it's important for a person to attend that meeting who doesn't usually, and the coordinator would make sure that person has access to the whole court team to give up-to-date information. It may be that a coordinator says the treatment provider is recommending a sanction, and the judge needs to have more understanding about what that's about. So the court team coordinator is very important to make sure that all sides are informed. It may be that the coordinator needs to let a treatment provider know. The judge is getting very concerned. The last time the participant was in court, the judge was not convinced he was really making good progress. And do you really think he is making good progress? Because if you think he is, you need to make a case for this person not getting sanctioned. But if you're not watching close enough and the judge is right that this person doesn't look like they're proceeding very well and progressing, you please take a reassessment of this person and see, are they in fact just drifting through the program doing time? So I hope that gives a flavor of what the coordinator does. Now, where does the court case manager, and this is where I need to check, because you can have case managers both on the treatment side and on the court team side, but is this a case manager on the court team side, I assume, right? Monica, do you know?
I am not sure.
All right. Well,
I'll let you know if they follow
about case managers on the court team side. Yeah, and if somebody says, no, that's not what I meant, please back at me. The case manager, I think, is making sure that the participant is, this is the way I would see it, the participant is being linked to the services that they need and that they are being supported in getting to the treatment provider assessment, that if they're needing help with physical health issues, to work with the treatment provider to make sure they're getting that medical evaluation, that if they're having trouble with housing or the scheduled treatment team is interfering with the work of the person and the participant may be talking to the participant about that but not bringing that up with the treatment provider. The manager is, I see it as an advocate for making sure that the participant is linked to all of the services they need and that nobody is missing anything, because we're all very busy, and the treatment provider has a certain focus, but the case manager makes sure that the participant is getting the needs met, and that the treatment provider is aware of something the participant may be telling the case manager, and invite the case manager needs to be informed about something that the participant needs help with to help link them. There may be reports from the probation officer, parole officer, or something that you know, I see the case manager as somebody on the individual level versus the drug court coordinator who is looking overall at the functioning. The case manager is sort of like the coordinator, making sure that for this particular participant, there is good communication between all of the stakeholders. But I may have that wrong, and I'm open to you who are case managers saying, well, that's not what I sort of think of as my job, because again, I don't have all the answers. I want to make sure we open up conversation about this.
And David, the individual who submitted that said that they really are trying to figure that out too. So it's kind of unclear to them, and that's part of where that question came from.
Well, good. This is a good opportunity for redefined job descriptions because we need all hands on deck to this. But I gave you what I saw as a case manager, sort of like a coordinator on the individual level, and the drug court coordinator is making sure all of the systems of communication at the overall level are functioning well, and that all of the stakeholders have an opportunity to be at the table. Other questions or comments or disagreements? It's okay to disagree with this too. That's the way that we'll develop a better system, if we can have diverse opinions.
And if anyone does have any questions, just a reminder that you can go ahead and submit them through the Q&A panel at the bottom right of your screen. Also, if anyone who has dialed in would like to just speak and ask their question, you can just use the raise your hand function at the bottom right, and I can unmute your line. And I do just want to mention, it does look like we've had quite a few people who have been losing sound in today's session. The WebEx platform did install some updates which were supposed to fix bugs, but it looks like that may have backfired. So we'll look into that after this session, and we appreciate your patience.
And of course, the session will be on YouTube and on the American University website as well, Monica, right?
Yes, it will.
And hopefully that sound will be perfect.
Hopefully.
A reminder also, though, that on May 3, Tuesday, May 3, from 2 to 3 Eastern, we're still open to accepting any case vignettes or clinical dilemmas, or really any questions that have come up in terms of a person you may have been working with. And actually, that's another terminology issue. I was about to say a case you're working with. You're not working with a case, you're working with a person, right? So another semantic thing is that some systems are not calling people case managers, but care managers. So when we were talking about what is the role of a case manager, you might want to transition to you're a care manager, because that really defines you're managing the care, making sure people are getting the services that they need and are being linked to it. We're not impersonally working with a case. This is a person's life. That is very important. So just another little semantic terminology thing. Well, we either have tremendous consensus and agreement, or you have disagreements, but you may not be comfortable sharing them right now. We won't identify you if you write in. Carolyn, are you on, or do you have any comments or summarizing thoughts? She may not be on. Okay.
It does not look like she's on.
All right. Well, again, we don't have to string this out. If there really are no other comments, I just don't want to cut anybody off if you're just about to think about doing that. So let's sort of hold for 1 minute and show you some of the resources again. Where you can get more on this while we wait to see if anybody has anything else to say. And if not, we'll dismiss you and thank you for joining us. What do you think, Monica? Nothing else?
I think we're all set.
All right. Well, then I thank everybody again. And if any of you will be attending the National Association of Drug Court Professionals Conference in Anaheim this year, I will be presenting several presentations. On June 1, we'll be talking about moving beyond compliance to lasting change, how the ASAM criteria and evidence-based practices can help, and that's on June 1. On June 2, dealing with relapse, continued problems, working together to promote recovery, so covering many of the things we talked about. Then on Friday, June 3, I'll be sharing a general session with John Kelly, who I referred to. We'll be talking about the ASAM criteria, achieving lasting change, and then we'll repeat the relapse workshop. And then on Saturday, June 4, we'll be having a table at 7 a.m., some of the Ask the Expert roundtables, and any of you are welcome to come and join me there to talk about the ASAM criteria or anything else.
Great. Thank you, Dr. Mee-Lee, and I will also be there. So if you'd like to come over to the Justice Programs Office table, we definitely welcome you to do that. All right, I guess we'll wrap things up. Anything else, Dr. Mee-Lee, that you want to mention?
No, that's good. Thank you, everybody,
for
the conversation. Yeah, bye-bye.
Okay, bye-bye.